As you progress your patients from the passive to the active assistive postoperative rotator cuff rehab, it is imperative to recognize the likelihood of each muscle constituting the rotator cuff, as well as the scapular stabilizers, such as the lower trapezius and the serratus anterior muscles, existing in a partial to potentially a fully inhibited state. For an in-depth discussion of this science supporting this reality, as well as the guidance to successfully reestablish motor tone and responsiveness to these weakened muscles, I encourage you to view our presentation titled Fulfilling Optimal Healing Capacity. As movement health specialists, utilizing this foundational science, along with the capacities of the UE Ranger, to efficiently influence within the described therapeutic threshold, empowers you to both meet your own professional expectations as well as the hopes of your patients. So with this knowledge of facilitating motor responsiveness and grading a progressive strength recovery, absent the promotion of substitutions, let's put this understanding into clinical practice. Within this two-part video series titled Active Assistive Range of Motion in Initiating a Forward Reach, and its natural progression titled Active Assistive Range of Motion Initiating Functional Elevation. We describe the applications of this science as it pertains to rehabilitating each of the influential muscles associated with dynamic stability of the shoulder girdle, as well as illustrate the underlying motor activity and resultant desired biomechanical responses. From the earliest stages of reinitiating active motion on an active assistive level, it is imperative that your patients continue, as they learned in passive assistive motions, to trust the weight of their arm to that of the support of the UE Ranger. Much like your patients trusting their arm to your support during manual produced passive range of motion as a means of minimizing pain while realizing the capacity to achieve progressive in-ranges. Similarly, trusting the weight of their arm to that of the UE Ranger during the neuromuscular re-education portion of active assistive motion is crucial in facilitating the intended therapeutic influences versus that of prompting substitutions. As an example of the relaxation benefit, please take time to note within this view and the subsequent overhead view of the crucial combined participation of diaphragm-supported breathing to both, number one, deter undesirable elevations in motor tone via the autonomic nervous system's association with pain avoidances during the early stages of active movement recovery. Number two, restore the essential mobility requirements of the full torso and supportive shoulder girdle in reaching optimal movement health. We lead off with isolating the supraspinatus for three essential reasons. Number one, it has been demonstrated, due to its anatomical position, for the supraspinatus to be the most susceptible of all components of the rotator cuff to tissue degradation and resultant motor inhibition during pathomechanics such as that associated with subacromial impingement. As noted by the deepening color, recognize the representation of facilitating a graded reestablishment of the respective motor units within the supraspinatus muscle. Number two, in restoring its activation presence along with that of full and relaxed breathing, it has been shown clinically to serve a role of balancing the resting tone of the frequently hypertonic muscles associated with shoulder pathology, namely the upper trapezius, levator scapula, and the scalenes. Reestablishing proper resting tone and subsequent joint resting alignments, and we achieve a supportive capacity of both facilitating the activations of the remaining impaired rotator cuff muscles and ultimately the support of coordinated progressions of active mobility in restoring healthy biomechanics. As demonstrated, the capacity to isolate the facilitation of the supraspinatus muscle is accomplished by first setting the UE Ranger to just short of a patient's natural carrying angle or their most relaxed position. The key is that they are able to trust the weight of their arm to the device without their either feeling as if they are reaching down or being pushed up at the shoulder. Palpating over the intended muscle belly offers proprioceptive value in supporting your patient's ability to discern correct execution in facilitating the respective supraspinatus muscle while not recruiting an amplification of the unintended muscles. The actual activation of the supraspinatus muscle stems from a subtle combination of internal rotation of the shoulder, pronation at the forearm, and finally shoulder abduction into the scaption plane. Note that the correct combined movement should create an indirect or involuntary resultant force through the patient's thenar eminence. Successfully achieving both the restored motor responsiveness and resultant balance and tone facilitates the third essential benefit, that of supporting differentiation and mobility between the two components of the glenohumeral joint, leading to pain pattern resolution and resultant alleviation of associated limiting impairments. From an anterior view, note the capacity with supported internal rotation to simultaneously facilitate a graded participation of the subscapularis muscle. While it is the least common presentation for the subscapularis to be involved in most non-traumatic tears, it is best to ensure its contractibility and responsiveness with that of the greater rotator cuff muscles. As will be demonstrated in the second part of this video series, the subscapularis muscle is instrumental in re-establishing the commonly weakened lower trapezius. Thus, we want it to be both excitable and with sufficient endurance to consistently contribute to the rotator cuff's role as a forced couple as elevation ensues. Having now ensured the described tone and mechanical resting balance supported by the supraspinatus muscle, as well as reassured ourselves that the subscapularis muscle is fully available, we can now target the posterior rotator cuff and its synergistic contribution from the serratus anterior muscle during forward reaching. Note also the capacity within this reaching progression to integrate the natural supportive role of the foundational kinetic chain and, most importantly, the ipsilateral hip. To integrate is a Latin term meaning to make whole. Facilitating synergistic motor relations throughout the kinetic chain, absent the promotion of substitutions, is ultimately the most essential requirement in restoring the motor coordinations necessary to support the many movement options inherent to a healthy shoulder. As demonstrated, the capacity of the UE Ranger to support a seamless transition of facilitating a graded motor recovery to the variable roles of the involved rotator cuff is inherent to restoring dynamic stability to this versatile joint system. The actual activation of the infraspinatus and teres minor muscles, as well as the serratus anterior, stems from a subtle combination of external rotation of the shoulder, supination at the forearm, and finally forward reaching into the scaption plane. Note that the correct combined movement creates an indirect or involuntary resultant force through the patient's hypothenar eminence. As previously described, palpating over the intended muscle bellies offers proprioceptive value in supporting your patient's ability to discern correct execution in facilitating the respective muscles, while not recruiting an amplification of the unintended muscles. Within your efforts of integrating neuromuscular re-education with biomechanical recoveries, it is imperative to pay strict attention to the positional setup, movement sequencing, and finally the monitoring of both intended motor facilitations as well as fatigability of these respective muscles. While the established therapeutic exercise guidelines apply in this application, a good rule of thumb for your patients is quality over quantity. With the goal being that of restoring optimal movement health, we must ensure that we neither bypass weakened yet available motor units nor defer to motor substitutions. A fine line to be sure, yet you are the movement health specialist, and now you can equip yourself with the right tool for this challenging yet rewarding job.
We invite you to visit our website at ueranger.com, where you can find further resources to support using the UE Ranger with your patients. You'll be able to download a clinical manual and home exercise program, as well as view the supporting research and testimonials of both professionals and patients. We'd be happy to answer any questions you might have or discuss in more detail the features of the UE Ranger Movement Health System. Please call us at 402-210-8406 or email us at rehabinnovations@cox.net. We look forward to showing you how powerful the UE Ranger can be for your patients. and your practice.